Hello, everyone. We're going to get started. First of all, thank you for joining today's webinar, How Can BC Value Mental Health and Physical Health Equally? I'd like to begin by acknowledging that CMHA BC Division's office, where Kendra and I sit, is located on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. Now, before we dive into today's content, I would like to quickly address some housekeeping. First of all, there are two options for sound, either your computer's audio or telephone. We have an international audience today, so you'll find there's 3 toll numbers, one for Canada, United Kingdom, and Australia. Please ensure if you choose the telephone option that you dial into the number for your location. You also have the option to switch from computer audio to telephone or vice versa at any point during the broadcast if you need. Second, we will be recording today's session and posting the video online at beforestage4.ca. And we have included a PDF copy of today's slides in the handout section of the panel to your right. Please feel free to download the PDF at any point during the webinar or afterwards before closing the window. We've endeavored to make all the information from today's webinar accessible to eliminate the need for any kind of furious note-taking. We have a very exciting webinar in store for you. I'll quickly run through the agenda and introduce our presenters. So first, we have Kendra Milne, CMHA BC's own Senior Director of Policy, Planning and Government Relations. She will discuss the current political context in BC, specifically outlining the promising policy shifts we have witnessed since the 2017 provincial election and opportune areas for positive change. Kendra has been with CMHA BC for almost a year. It'll be a year in July. She formerly held the position of Director of Law Reform at West Coast Leaf and worked as a staff lawyer at Community Legal Assistance Society. Throughout her career, Kendra has been committed to using her legal skills as a tool for positive social change, with an emphasis on shaping provincial laws and policies to ensure that all people in BC can live with dignity and security. In particular, her work has focused on social assistance schemes, housing security, human rights, equality, and now mental health and addictions. Following Kendra, we'll have Chris Naylor, a senior fellow from the King's Fund, who will present all the way from the UK. Chris will discuss the UK context, where there was a political commitment to parity of esteem in 2014, and detail how that goal of valuing mental health the same as physical health has been and continues to be implemented. Chris conducts research and policy analyst for the King's Fund, one of the UK's most esteemed think tanks, and works as an executive coach with leaders in the health system to support change at the local level. He has particular interests in mental health and community engagement that stem from his background in research at the Sainsbury Centre for Mental Health and the Institute of Psychiatry. So after the presentations, there will then be an opportunity for audience members to pose questions. Please type your questions into the question section of your panel to the right. I'll then read them out to the presenters in this segment. If you would like to address your question to either Kendra or Chris specifically, please make a note of this in your submission. We'll try to get to as many questions as possible before the end of the webinar. Okay, without further ado, I'll turn it over to you, Kendra.
Thanks so much. So as Amelia said, I'm just going to give a bit of an overview about the current political landscape in BC before we get to Chris's experience about what we can learn from the UK. So as many of you may know, if you registered for this webinar through our Before Stage 4 email list, in 2016 and 2017, CMHA BC launched an election campaign that was called Before Stage 4, Changing the Way We Think About Mental Health and Addictions in BC. One of our primary goals of that campaign was to really make mental health and addictions an election issue in BC in our 2017 provincial election. We wanted to put it on the radar of the public and of all of the election candidates. We had a great deal of success in doing that. We reached almost 15,000 British Columbians, and we had really great public support and endorsements from individuals and organizations throughout BC. As a result of that campaign and other hard work from folks around BC, we saw a real significant increase in attention paid to mental health and addictions in all of the party election platforms. And of course, as a result of the election, we now have a new government who has implemented one of our primary recommendations from the Before Stage 4 campaign, and that was to establish a designated ministry and minister of mental health and addictions to really be a central point of policy and accountability for those services in BC. So you'll see on your screen now a bit of an overview of the Minister Judy Darcy, our Minister of Mental Health and Addictions, her mandate letter from the Premier. And you'll see the three key aspects to her mandate for her term is to develop an immediate response to the opioid overdose crisis that BC has been and is unfortunately continuing to experience, to develop a mental health and addiction strategy to really transform our mental health and addiction systems in BC with a focus on early intervention, prevention, and youth services, and to consult with stakeholders when developing the plan to deliver quality services. And part of the reason that CMHA BC has started this webinar series is because BC is currently starting public engagement about what we know will now be actually 2 mental health strategies in BC, an adult and a child youth strategy, about what the content of those strategies will be. So the engagement is open, and I'll just get Amelia to click the slide forward. And at engage.gov.bc.ca, you can find there's a bunch of boxes on different provincial engagements that are happening, and one of them is on mental health and addictions. And that engagement we expect to be open until the end of August of 2018, with more details about what the consultation will look like going forward. But we're hoping that this webinar series will kind of arm folks and provide some information to really be able to take advantage of that consultation to make sure that we build some robust plans in BC. Slide, thanks. So just a quick rundown of what we've seen from our new ministry and the new government since it's come into power. So we're just over a year, or around about a year. In terms of commitments so far, both in the update budget in September 2017 and the 2018 budget in February released, here's what we know so far. We know that the new ministry's budget is quite small. So it's projected to be about $10 million a year going forward in future years. And that's because the intent of that ministry, we now know, is really to focus on policy research and evaluation, and service delivery of mental health and addiction services will continue to flow through the Ministry of Children and Family Development for child and youth services, and the Ministry of Health for the adult system. So in addition to what we kind of understand about what the new ministry's tasks will look like, we also know that there's been a commitment of $290 million over 3 years, which is initially really focused on a response to the opioid overdose crisis. But we know from the budget notes there is an intention for that money and for potential additional funds to be dedicated towards building out the mental health and addiction system once we move beyond this crisis response phase of the opioid crisis. We also know that there has been significant, so $150 million over 3 years dedicated to new initiatives around team-based primary care. And we've seen some very recent announcements about what that may look like in BC. And so we know that's going to include primary care networks of practitioners. So those are being launched now in 5 communities with the expectation that that will be rapidly expanded to many communities over the next 12 months, and then up to 70% of communities in the coming 3 years. And urgent primary care centers for people without access to GPs right now, or for folks that are currently accessing services in emergency rooms because they need medical assistance after hours or on the weekends. So those primary urgent care centers are intended to kind of take pressure off the ERs. And community health centers, well, there'll be hubs of health and other social services, and we don't quite know what those will look like yet. And in addition to those, we've really seen recent announcements about increased investments in 200 new physicians and 200 new nurse practitioners. And I will say right now that it's unclear how mental health and addiction services will fit into these new initiatives around primary team-based care. So that's an opportunity that we really think there's potential to influence going forward. And finally, particularly in budget 2018, we saw a real investment in social determinants of health. So the kinds of services that we know people need in order to stay healthy in their community, and also to recover if they experience mental health or substance use related illness. So we saw significant investments in affordable housing, really across a range of different models of housing. We saw significant investment in affordable childcare throughout the province. And we saw the beginning of what we know are deeply needed investments in our income and disability assistance systems in BC. In addition, as I said, the new ministry's focus has thus far been very much focused on addressing the ongoing opioid overdose crisis in BC. And we've heard the minister say a number of times that in order to support folks to improve their health and well-being overall, they have to be alive in order to do that. So we're really seeing an emergency response to what's been happening. And so there's a number of initiatives that are set out on your screen there, including a new overdose emergency response center at Vancouver General Hospital here in BC, rapid increase to prescribed opioid substitution drugs and opioid substitution therapy, significant investment in naloxone kits and training to administer naloxone, and public education. So unfortunately, because of, and it's not, I would say, despite these significant efforts, both by government and throughout community, unfortunately, we really have not seen a significant reduction in overdose mortality rates. We saw a little dip, and unfortunately, in May, this last month, we learned that there was a significant spike again in March of this year, which was really matching again the peak of the crisis. So there's significant work left to do in that area. And on this topic, I just wanted to flag for everyone that the National Office of CMHA recently put out a really significant and lengthy evidence-based policy paper in response to the overdose crisis that is really calling for a national plan, a national evidence-based comprehensive plan to address the issue. And it's really focused around treating substance use as a health issue and not as a criminal issue or a moral failing. It recommends taking a robust, comprehensive approach to addressing it using the 4 pillars of drug policy, ranging from prevention to treatment, all the way to harm reduction. And it also recommends the decriminalization of personal possessions of all substances. So if you're interested in accessing that document, it has some really good research in it and some really strong recommendations. And you can find that on CMHA's national website, and it's called Care Not Corrections. And I'll just flag one more thing on this, that if any folks are joining our webinar from BC and may be interested in applying for a community-based overdose prevention grant, one of the initiatives is a crisis innovation fund. So the Community Action Initiative in BC right now has a call open for community-based grants, and you can find out more information about that on their website, which is www.communityactioninitiative.ca, and the deadline for applying for those grants is July 13th. There's been some other announcements to date that I'll just flag for you, one of which was a previously committed new facility called the Center for Mental Health and Addictions on the former Riverview lands here in the Lower Mainland. We've seen an additional commitment to the Foundry model in terms of expanding it further throughout BC. So that's the integrated service model for children and youth that we've seen developed in a number of communities. So that's going to continue to expand to additional communities. And we've also seen a really rapid increase in development of temporary modular housing units with wraparound supports. And that's a really kind of urgent response to our homelessness crisis here in BC. And the supports are really geared at supporting people with mental health and addictions. Unfortunately, what we've also seen in response to that is we've seen significant pushback at the community level. And so we've seen some local governments actually decline the opportunity to have this investment come into their community because of a lot of stigma, stereotype, and discrimination about what it means to have supportive housing for people experiencing mental health and addictions issues. So with all of that in mind, where are we headed? Well, as I said, we know that the Ministry of Mental Health and Addictions has committed to producing in the very near future 2 provincial strategies to transform BC's mental health and addictions care system. There'll be one for adults and one for children and youth. And the leader of that initiative will be Minister Judy Darcy. And she's made a number of statements and uses language that really reflects to us at CMHA a commitment to parity of esteem and valuing mental health equal to physical health. We've heard her say things like she wants to build a system where every door is the right door in terms of accessing supports. We've heard her borrow from our Scottish colleagues about building a system where you can ask once and get help fast. And we've also seen, you can see a quote on this slide there. She uses a comparison to physical health care quite often, and I believe actually the Premier also has used this comparison, where I've seen her use it in a conference where she said, you know, if I fell off this podium right now and I broke my leg, everyone would know what to do. They would know where to take me to the ER. At the ER, they would know exactly what treatment I needed. They would know when and how to refer me to specialists, and I would get those referrals. And I would get the supports that I need, and I would likely get sympathy in response to that. And she's made those comparisons to the mental health system, where we know, because of the fragmentation and lack of services, that's not the case right now. So we know that our current system, the pathway to care is not clear, the standardization of care is not always clear, and we certainly know that experiencing mental health and substance use related issues often leads to a lot of stigma instead of sympathy. So the good news is that we have a minister who, in our view, has really made a commitment to increase the way that we value our mental health in comparison to physical health. And so with this opportunity in mind, we wanted to invite Chris Naylor here to help us understand the UK context, because in the UK, they've had a political commitment to parity of esteem, or valuing mental health the same as physical health. And we want to know how that worked and how it's worked out in terms of practical implementation and change for people on the ground in their communities. So Chris, we're very eager to learn from you about the UK experience. And we're particularly eager to learn about how to change and move from political commitments to changes in reality for people experiencing mental health and addiction issues. So thank you so much for joining us, and I'll pass the webinar over to you.
Great, thanks very much, Kendra. Good afternoon, everyone. It's a real pleasure to join you today. I've called my presentation On the Road to Parity because I want to stress that this is very much a journey that we're on. We're not at the destination yet. Just listening to Kendra's presentation there, I think there are a number of similarities between some of the work that's going on in BC and some of the work we're doing here in England, and there are some differences as well. So there are contextual differences. Addictions is not as high on the political agenda as it is in parts of Canada and the US at the moment. But there are some commonalities in terms of the kind of things we're trying to do. I'd certainly say that we've enjoyed a real degree of political attention for mental health in the UK in recent years. So Theresa May has spoken of mental illness as being one of the burning injustices in society that she wants to address during her time as Prime Minister. And going back before then, this has been a slow build, really. I'd say over the last 10 to 20 years, mental health has been gradually climbing up the political agenda. And it's been a real transformation, actually, particularly in the last 5 years or so. I would say, is it a priority for politicians now? Increasingly it is for many politicians. Yes, it is higher on their radar than it used to be. Is it a priority for the public? Absolutely it is. All of the survey data show that mental health is something that people really want to see improvements on. Is it a priority for the people running the health and care system? Not always. To be honest, I would say that it's a really mixed picture. There are some who have seen the light, and there are others whose priorities still lie elsewhere. Our argument that we've made at the King's Fund in recent years has been that if you get mental health right, you stand a much better chance of getting the whole healthcare system right. But I don't think we can say that that argument has been accepted universally yet, but we're making progress. So if we go on to the next slide, please. One thing that we have benefited from in the last 2 or 3 years is we have quite a clear policy framework for mental health in England. The 5-year forward view for mental health sets out the priorities for the country. It's a plan that has a good deal of consensus behind it and draws quite well on the available evidence. There's a few things that are going on through this plan. So in part, it's about improving access to some of the services that have the strongest evidence base behind them, things like early intervention teams for psychosis, crisis resolution teams, a lot of focus on services for children and young people, acknowledging that that has been an area of real weakness in England, as in many other countries to date. There's also been a focus on mental health outside of the health and care system itself. So using things like the individual placement and support model to help people to return into employment. I know IPS is a real focus in many parts of Canada too. So we're trying to expand that approach. There's been some work done around prevention, particularly suicide prevention. And one of the themes that was identified in the 5-year forward view as being one of the top 3 priorities for the next few years is integration. So trying to develop a more integrated approach to mental and physical health in particular. If we go on to the next slide, the 3 areas that I'm going to cover in this presentation are firstly around parity of esteem, secondly around the integration agenda, and then I'm going to close by saying a few words about what we're doing on prevention and early intervention. So coming on to the next slide, parity of esteem, we don't have a single sort of legal definition for what we mean by parity of esteem, but I think the general consensus is that we're talking about equal access to effective care and treatment. We're also talking about equal efforts to improve the quality of care, equal status within healthcare education, and overall equally high aspirations for service users. One of the levers for change in recent years has been that when the legislation that governs the NHS was reformed in 2012, one of the amendments that was inserted into that legislation was that the NHS now has a legal responsibility to try and promote parity of esteem between physical and mental health. And in the time since that legislation was passed, NHS England have done, I would say, 3 main things to try and put that into practice. The first is that for a few years now, we've used waiting times as one waiting times targets as one tool to drive up access to care in other parts of the NHS, so for physical healthcare treatment, but there haven't previously been waiting time targets, equivalent targets in mental health. That's changed now, so in 2 areas, for psychological therapies and also for early intervention services, there are now waiting time targets that are measured and monitored by the government. The second is that there is a expectation that local commissioners who plan and purchase services within the NHS should each year raise their spending on mental health in line with the overall increases in their annual budget. So that's what we call the mental health investment standard. NHS England nationally monitors what local commissioners are doing on that, and if their spending on mental health is in line with that principle. And then thirdly, NHS England have also been applying a degree of pressure to make sure that mental health is included in wider efforts to improve health and care. So as an example of that, we have 44 sustainability and transformation plans which cover England, and the mental health team at the national level have been quite assertive in saying, you know, we expect to see mental health included in these plans. We want there to be an equivalent degree of attention being placed on this to other areas. If we go into the next slide, say a word or 2 about that investment standard. So what's happening with the money? One of the difficulties is that new money has been made available through the 5-year forward view, but most of it isn't ring-fenced. So it goes into the general pot of money that local commissioners receive, but it's not kind of ring-fenced for mental health. So NHS England have been trying to put in place a system that they can use to monitor how that money is spent. They've developed a mental health dashboard, which is available online, and which makes public a whole set of data. Some of it is about the money and how money is being spent. Some of it is about outcomes measures. Some of it is about process measures. But the idea, the principle of this is to put all of that into the public domain. So this snapshot you can see on the slide is a tiny part of it. You can go on, you can look at the national picture, or you can drill down to your local area and see how your area is performing against other areas in terms of the priorities that the 5-year forward view has laid out. If we go on to the next slide, one of the questions that people have been very keen to answer is whether this mental health investment standard is being met. Overall, nationally, it is. Funding for mental health has started to increase. 85% of the 200 or so local commissioning organisations we have in the NHS met that standard. But there is a question about what that means, how we interpret that. So anecdotally, we believe that there may have been a degree of gaming of that. So there's not there are not any kind of hard rules in terms of when you're reporting what you're spending on mental health. What you include within that budget is to some extent down to each of the local commissioning organisations, and that creates an incentive to have a fairly loose definition of what we include within the mental health budget. The other thing is about where that money goes. So we've done some analysis looking at so NHS England have been looking at the money that flows out of commissioners. We've looked at it the other way around and looked at the money that's flowing into mental health providers, and specifically NHS providers. So in England, 80% of mental health care is provided by the NHS, and the other 20% is provided by NGOs and commercial sector organisations. But looking at this graph here, what we can do is compare NHS acute trusts, who provide mainly physical healthcare, with NHS mental health trusts. The orange line is the acute trusts, and the purple line is the mental health trusts. And basically what this shows is that, yes, the funding available going into mental health trusts has increased over the last 4 years or so, but it hasn't increased as fast as money going into other parts of healthcare, into physical healthcare. So there are all kinds of complexities about how you interpret that. But I think overall it doesn't appear to be in keeping with the spirit of parity that the policy has put in place. There are also big issues with data quality in terms of the mental health dashboard that I mentioned. The quality of that data has been improving incrementally, but I think at the moment it's not as reliable as the data we have to monitor the performance of the physical healthcare system. And there's also a time lag, quite a considerable time lag, before that data is put into the public domain. So in accountability terms, it's still not perfect, albeit it is an improvement on what existed before. So if I moved on to the second of the three areas, which is around integration, the mental health 5-year forward view I mentioned is itself part of a broader strategy that covers the whole of the health and care system in England, which is also called the 5-year forward view. And one of the central parts of that strategy is a call for new models of care which dissolve the traditional boundaries in the health system. And There is an objective to make the biggest national move to integrated care of any major Western country. So the question is, how does mental health fit into that kind of broader move towards integration? Coming on to the next slide, we at the King's Fund have done several pieces of work over the last 5 years that have tried to make the case that we need a closer relationship between mental health and the rest of the healthcare system. I think that message has been heard. If we could go on to the next slide, Simon Stevens, who's the chief executive of NHS England, has used the phrase triple integration. So he says that triple integration is what we need if the NHS is going to be sustainable in 5 years' time. And that means integration of health and social care services, integration of primary and secondary care, so hospital and out of hospital care, and then thirdly, integration of physical and mental health care. So I guess what we would argue is that when it comes to the third of those components, so far the thinking at the policy level is less well articulated than on the other two, and in terms of action at the local level, whether there's a lot going on, but it's a lot of it is piecemeal and going on in pockets of innovation across the country. So we think, coming on to the next slide, that if we're going to get a more integrated approach to mental health, it's a whole system change that we need. We need mental health to be embedded in everything from preventative public health work through general practice through to specialist hospital care. Now, the problem is when you say we need a whole system change to policymakers, they quite understandably often have to say, okay, but what are the 3 or 4 things that we really need to do in the next 2 years? So on the next slide, we have the 4 areas that the national policy has picked out as being priorities in relation to integration of mental and physical health. Firstly, we've had the Improving Access to Psychological Therapies programme in place for about 10 years now. The IAPT services, as we call them, are now spread across the country. One of the shortcomings of the IAPT programme historically has been that the first generation of IAPT services was set up very much to treat people with mild to moderate depression or anxiety and without too many other complicating factors. So people with physical health comorbidities were often screened out and not accepted for referral to IAPT services. So that's changing now. This is one of the areas where the mental health 5-year forward view is investing, is to expand the IAPT program with a specific focus on making it work for people who also have physical long-term conditions. The second area, the second priority is about expansion of liaison mental health or liaison psychiatry services in acute general hospitals, so in emergency departments and in inpatient wards. The third one is around investment in perinatal mental health services, and I would say that perinatal mental health is one of the areas where physical health and mental health really do come together. And then the fourth is the flip side. It's about the physical health of people with mental illnesses. We all know the quite shocking statistics about premature mortality among people with mental illnesses, and there are measures being put in place to try and close that gap. So I'll say a little bit about each of those 4 and how much progress we've made since the policies were introduced. So starting with the psychological therapies, if we could go on to the next slide. There are 37 early implementer sites where they are trying to expand psychological therapies for people with existing physical health conditions and also for people with medically unexplained symptoms or persistent physical symptoms that have a psychological component to them. And some of the data that's coming out of those pilots is really encouraging, particularly in terms of financial return on investment. Some of the sites are finding that these services are more than paying for themselves because of the reductions in activity in other parts of the health system, in primary care, in emergency departments, and so on. So that's all very encouraging, and on the basis of those results, the latest planning guidance for the NHS says that every clinical commissioning group in the country should be commissioning one of these expanded IAPT services. I think it's important to flag, though, that IAPT is only going to be one part of the solution. The implementation guidance that was recently released really stresses that we also need to be strengthening other parts of the system, like existing clinical and health psychology services, and making sure that there are clear arrangements for joint working between those services and IAPT. Coming on to liaison psychiatry services in acute general hospitals, there has been real progress being made here. So the proportion of hospitals that have no liaison mental health service at all is becoming smaller and smaller. At the moment, the target is to get 50% of hospitals up to the Core 24 service standard by 2020. And we're not on track to make that. So it's improving, but it's not improving quickly enough. And the main thing that's holding us back is something that is actually probably one of the biggest issues in mental health in England at the moment, which is the workforce and the lack of availability of trained staff. So in some parts of the system, money is going in, but actually the staff that we need to buy with that money simply aren't available. And of course, it takes a long time to train people. So the workarounds that we're developing are about putting in place things like a new credentialing process that means that existing consultant psychiatrists who aren't liaison professionals can quickly get credentialed in working in liaison environments, in physical healthcare environments, and move into those kinds of roles. Coming on to the next area on perinatal mental health, in some ways it's a similar story. So a quote from a perinatal psychiatrist, Liz McDonald here, who's done a lot of work at the national level, really reflects that things are starting to happen here, but again, workforce shortages and training needs are the big barrier, and that's what's stopping us from making faster progress than we might. Finally, coming on to the fourth priority I mentioned around meeting the physical healthcare needs of people with severe mental illnesses. The latest data on this is quite sobering, actually. So these graphs are from a study by Hayes et al. In the British Journal of Psychiatry last year. And what they show is on the left, we're looking at mortality rates for people with bipolar disorder, and on the right, it's the same for schizophrenia. And going upwards is bad news, in short. So we were making some progress. We were closing that mortality gap for the first few years of the 21st century, but it has started to turn the other way over the last 10 years or so. The data only goes up to 2014, so we don't know if we've managed to turn the corner again in the last 3 or 4 years, but certainly in the period running up to that is not encouraging. The authors of this study have various hypotheses about what might be going on here. In part, it might be about the effects of austerity. We've been living through a period in the UK of a real slowdown in public spending in health, but also even more so in other public services. And it may well be the case that the impact of those spending cuts has been felt disproportionately by people living with mental health problems. A second hypothesis is that it's around smoking, and that actually we know we've been more successful at reducing smoking rates in the general population than among people with severe mental illnesses, so that might account for some of this. So much work still to be done. The last thing I wanted to mention on integration coming on to the next slide, was about some of the things that we haven't done as much on. So one area that I think is hugely important and that lots of local areas are starting to look at, but which national policy has been largely silent on, is mental health in primary care, mental health in general practice. It's an area where I think local areas are ahead of the policymakers on this one, because lots is going on locally. One of the big changes that we are seeing in primary care in England at the moment is a move to kind of primary care at scale, more integrated ways of working. Kendra, in her introduction, talked about moving to team-based models of primary care, and that's very much the direction we're going in England. One of the most common ways that's happening is that GP practices are clustering together in what are often called neighbourhood arrangements. A typical neighbourhood covers a locality of a population of perhaps 30 to 50,000 people, and wrapped around that cluster of practices is a multidisciplinary team of primary and community health professionals and social care professionals. One of the big unanswered questions, I think, is what is the appropriate form of mental health input into these kinds of team-based primary care arrangements, into these multidisciplinary integrated care teams. So that's something that we still need to figure out. Coming on to the final area that I wanted to talk about, which was prevention. The 5-year forward view gave an organisation called Public Health England, which is a part of the Department of Health, the responsibility to run a programme of work on prevention. So over the last year or two, they've been delivering what they're calling a Prevention Concordat for better mental health. That's included quite a few different components to it. I've included the link in the slides so that you can look at it in your own time, because I think there are some resources that you might find useful. There is a consensus statement that different organizations are signing up to. There are various planning tools and so on. If we go on to the next slide, this gives the consensus statement that Public Health England are asking organisations to sign up to. I won't read it all out, but just the first line: to transform the health system, we must increase the focus on prevention and the wider determinants of mental health. We recognise the need for a shift towards prevention-focused leadership and action throughout the system. So that's the vision, and actually we've been pleased to see the number of different types of organisations signing up to this consensus statement. So that's included NHS organisations, local governments, other public agencies, but also private bodies, so employers, NGOs, representative bodies of various kinds. So that's been quite encouraging. Coming on to the next slide, the other resources that have been made available through the Prevention Concordat have included various resources for planners and commissioners, trying to set out what good prevention planning might look like. So it needs to involve high quality needs assessment, it needs to involve good partnership working, defining success outcomes, and so on. One final thing I'd draw your attention to is that one of the resources that's been produced is a return on investment toolkit that allows local commissioners to look at, if you were to invest in various preventative interventions, what's the financial payback you would expect to get, and which part of the system would that fall to? So how much of that return would come to the health system, how much of it would come to the police, how much of it would come to other parts of the public sector, and so on. And the kind of interventions they've looked at in that are things like debt advice, tackling social isolation among older people, school-based interventions like anti-bullying initiatives and social emotional learning programs, suicide prevention measures, workplace well-being programs, those kinds of things. So there's been lots of good work going on to lay the foundations for work on prevention. Have we fundamentally reoriented our mental health system towards the more preventative model that we want? No, not yet. We're a long way from doing that. And to some extent, I guess I'd say that we're swimming against the tide because as I mentioned earlier, all of this is happening at a time when other public services have been cut and some of the social determinants that drive mental health problems have been getting worse rather than better. So it's a challenging environment, but there has been good work being done. So I've got one final slide just to offer a few concluding thoughts. I think generally in England, what we see at the moment is a really welcome political focus on mental health. We have a clear framework for action that has a broad-based support behind it, but the issues around accountability and measurement are still very tricky. One reflection I would offer is that I think the mental health dashboard that we've developed is probably better as a tool for assurance than it is a tool for enabling improvement. So you really need to know which when you're choosing outcome measures, which of those are you trying to do. There are issues which I think haven't had the attention they need to have, mental health in primary care being one of those. I think we also need to look at again at core services for mental health. One critique of the 5-year forward view is that it's put a lot of emphasis on strengthening specific parts of the system and quite specific functions, things like perinatal mental health. But we haven't thought enough about the kind of the sort of bog standard mental health offer, our community mental health teams, acute psychiatric wards, and so on. There's also, despite the focus on integrated care, still big problems in terms of fragmentation in some parts of the system. I haven't talked much about addictions or substance abuse, but that is still an area in the UK where addiction services are very often delivered in a very fragmented way separately from other mental health services. So that's a big problem. We're about halfway through the 5-year forward view, and I think people are already starting to think about what comes next. One thing we do want is that for the next strategy to be a mental health strategy, not just a mental illness strategy. And if we're going to be thinking about mental health in a kind of whole population way, then we need to have cross-governmental ownership beyond the health sector. So overall, I'd say we are on the road to parity, but it remains an aspiration. It's not a reality yet. Thank you. So I think there's a few minutes left for questions for me or for Kendra, if there are any coming through.
Yes, thanks, Chris. So please, if you have questions, write them into the question box, and you can specify if it's for Chris or Kendra, and I will pose it to them. To get us started, Kendra, did you have any questions you would like to address to Chris?
I do, yes. In particular, Chris, I was just wondering about your comments about some of the, well, I guess in general, I'm just wondering, so we're sort of embarking on this process to build what I think will be kind of the parallels to the UK 5-year forward strategy in BC. And I'm wondering if you could change that document today. I'm wondering if there's anything particularly around accountability that you wish was in that document. So things that we can learn that perhaps are missing from that document that may help us in terms of making sure as we go forward, our plans are really meaningful for folks.
Yeah, I guess the first thing I'd mention is the point I touched on at the end there, which was that I think we sometimes get in a bit of a muddle about are we measuring things for the purpose of assurance, or are we measuring things for the purposes of enabling improvement at the local level? And I think the dashboard that we developed probably functions better as a tool to give NHS England at the national level assurance that in process terms the kind of things they wanted to see happening through the 5-year forward view are happening. But I'm not sure it gives local systems the information that they'd need to really reflect on where they are, benchmark themselves against other local areas, and think about, okay, where do we go next in our improvement journey? So that's one issue that I would definitely highlight. And the other things that I would kind of, encourage would be to make sure that you do think about things like public health perspective and primary care alongside all of the issues around specialist mental health services.
Great, thank you. The other thing that I was wondering is, you mentioned right at the beginning that in terms of kind of a culture of accepting parity, that it's a bit of a mixed picture in the UK, and that in particularly within the system, that's still a bit of a challenging conversation. And I was wondering on your thoughts. I mean, I think we all grapple with how much a policy can change that, or sort of direction from above can change culture of systems. But I'm wondering if you have thoughts on if you think progress has been made in the UK, or if you think there's anything that's sort of helping that conversation along.
I think progress has been made. I guess what I'd say is that people working in the NHS have a lot of targets, a lot of things they are held accountable for, and they get a sense. So there are the targets that are written down. There are things that in theory they're going to be held accountable for. But then separate from that, there's the mood music that comes from the conversations that they have with people in national organisations, and which gives them a sense of which of these targets am I really going to be held accountable for, and which ones of them can I probably get away with letting slide. Because we're in challenging times, and people do sometimes have to make difficult decisions about where to prioritize their efforts. And to be frank, I think sometimes people know that missing some of the targets on mental health is probably not going to cost them their job, whereas missing some of the targets around waiting times in emergency departments in acute hospitals might. So there is, I guess, a point about making sure that the policy that's there on paper is consistent with the messaging that's sent out by people in their kind of interactions between national and local organisations.
Great.
So we'll wrap up just with one more question from the audience. It's for both presenters. And the question is, are there investments being made in profiling addictions clients of the mental health services to draw clear indicators of causality to educate us well in terms of developing more proactive interventions?
Do you want to talk on that, Kendra, from a BC perspective first, or?
Go ahead.
Okay. I guess I would say that I'm not sure to what extent that profiling is being done in England. The overall system that we have here is one in which addictions sits quite separately from the rest of the mental health system. So it's actually commissioned separately. Substance services, addiction services are commissioned by local government, whereas other mental health services are commissioned by the NHS. That split was created by the reforms we had in 2012, and I think has been really problematic. It's really kind of driving a wedge between what needs to be an integrated service offer.
Yeah, I think in BC, I think if there is any, it's hard to imagine it as a positive to the overdose crisis we've been experiencing, but there is certainly a significant amount of public conversation happening around both the inadequacies of our current system and more conversations around causation. So we're certainly having more conversations around things like, for example, there's many very high profile stories of individuals who have died as a result of an overdose, and there's conversations from their family about happening in the media all the time about they struggled with mental health issues their entire life, and their use of substances was really an attempt to try to deal with the consequences of other aspects of their life. So I think we're certainly having those conversations more, and I also think we're starting to have a conversation more around the influences of trauma on people's both experiences with mental health and substance use issues. So I'll actually just flag that the next webinar that we're doing in this series, which will be on June 27th, and we'll be sending out some info early next week, will actually be with a physician and an expert on Indigenous health here in BC about the connections between particularly childhood trauma and mental health and addictions, and the role that poverty and economic insecurity can have. So really getting at those the underpinnings of social determinants of health and what's happening in BC and where we can move, because I do think those conversations are starting to happen more.
Well, great. Thank you so much, Chris and Kendra, for your presentations, and everybody who joined the webinar today. A quick mention before you sign off is there will be a short survey in a pop-up window when the webinar concludes. We'd really appreciate if you could take a minute or two and fill out the survey. Your feedback is very helpful to us to help us design future policy webinars that address topics that are of interest to you. So that's all from us. Thank you again, everybody. Enjoy the rest of your day.